Good morning, everyone, and welcome. My name is Brent Atkinson, and I have the privilege of serving as Vice Chair of the Board for University Hospital Kingston Foundation, and I really appreciate you all being here today for our Circle of Care webinar series. Before we begin, I want to acknowledge how grateful we are that you've taken time out of your morning to be with us. Many of you are longstanding supporters of healthcare in our region, and your generosity truly helps make the extraordinary work happening in Kingston possible. For those of you who may be newer to the foundation, UHKF is the fundraising arm supporting both Kingston Health Sciences Center and Providence Care. The reality is that many of the most important investments in capital equipment, medical research, innovation, and education are not funded by government. They're made possible because members of the community, people like you, choose to invest in the future of healthcare. We're pretty blessed with that in Kingston to date, despite operating two of the oldest hospitals in the country. Our foundation role is to engage and inspire our community and to support the exceptional care being delivered every day by our physicians, researchers, nurses, and clinical teams. Today's webinar is part of our Circle of Care event series. Each year we host 2 invitation-only donor luncheons and 1 public webinar, giving our community the opportunity to hear directly from some of the remarkable medical leaders working right here in Kingston. The conversations allow us to explore emerging health challenges, cutting-edge research, and the innovations that are shaping the future of medicine right here in Kingston. And I think you'll agree that we are extremely fortunate to have this caliber of expertise right here in our own community. A couple of quick housekeeping notes before we begin. This webinar is being recorded and will be available on our website and YouTube channel afterward. We expect today's session to be about an hour, and we will have time for Q&A at the end of today's presentation. It's now my pleasure to introduce today's speaker. We are incredibly fortunate to have Dr. Susan Mullen with us. Dr. Mullen is an internationally recognized neuro-ophthalmologist at Kingston Health Sciences Center, a clinical scientist, and the CMO Chair in Research and Innovation at University of Queens. She also serves as honorary professor at the University of Birmingham in the United Kingdom. Dr. Mullen has authored more than 200 peer-reviewed publications, and her collaborative leadership has been recognized globally, including being appointed as the first ever international board member of the North American Neuro-Ophthalmology Society. She joined Queen's University in August of 2025 and is currently establishing an optic nerve center of excellence at Hotel Dieu Hospital right here in Kingston. This initiative will create a unique environment for transitional research, attract industry investment, and bring together disciplines with one powerful goal: preventing blindness caused by disease of the eye and brain. Today's talk explores a fascinating intersection between space exploration and human health, and how research connected to astronauts in orbit may unlock solutions for patients right here on Earth. Please join me in welcoming Dr. Susan Mullen.
Thank you so much, Brett, for that kind introduction. And it is a real pleasure to be here this morning. So it was quite difficult to work out a title for my talk, but I thought Eyes to Mars, a Cosmic Health Crisis. We do know that 1 in 7 Canadians have some form of eye disease that could lead to permanent blindness. And the difficulty is really challenging and channeling funding for research, particularly for eye health. It sometimes gets squeezed out by some of the other big diseases, and it's highly prevalent and highly relevant. So I'm really delighted that you're all here today. So I want to take us from some of our Earth diseases to something called spaceflight associated neuro-ocular syndrome. This condition wasn't first noted when we started our space exploration, but started to be noticed when we had longer duration space flight. And at the present time, There are many different space agencies across the world, including our Canadian Space Agency, who are really exploring Earth's low orbit with the establishment of a moon base, Artemis, because the International Space Station has existed for quite some time and is due for decommissioning in the coming years, having been bombarded with not only sort of microparticles, but radiation. And over the next years, we're planning our trip to Mars, and we hope that that will happen around 2038. But there's also commercial space agencies, and they're increasing activities, and more people are looking to fly into space, not only those highly trained astronauts, but fee-paying clients. And there are a magnitude of different medical risks associated with spaceflight, and these must be carefully balanced. But one of the highest priorities to solve is the consequence of microgravity on the eyes, this spaceflight-associated neuro-ocular syndrome, which I'll refer to as SANS as we run through the talk. So what happens when an astronaut or a cosmonaut jettisons from Earth? Well, you get 2 liters of fluid that normally stays in your lower extremities, your lower body, that comes up into your neck and to your head. You come into a microgravity environment where our normal mechanisms to clear fluid in the neck and the brain don't work as well. And we're up on the space station for many months in certain circumstances, with a highly difficult environment to work in. If you have a medical problem, repatriation costs millions and millions of pounds. And not only does one astronaut need to be repatriated, the whole crew is repatriated to Earth if there's a single medical problem. So you can understand the high stakes involved in understanding what goes on with our normal bodily functions when we go into space, and how that could start to cause problems. But for the eyes, it can cause optic nerve head swelling, akin to something we call papilledema on Earth, but it also causes brain changes. It causes other things as well. So as the astronauts first found out, they needed space anticipation glasses. And for any of us that have become presbyopic when we hit our 40s, 50s, and 60s, that need for reading glasses, but they get quite dramatic shifts in their vision. And so this is a real risk for working on the space station if you're not actually able to see the instruments or the experiments that you're doing. The eye nerve swelling doesn't happen immediately. It usually happens about day 30. And some astronauts start to get folds in the retina and in the choroid. And this could be akin to changes that we see in age-related macular degeneration here on Earth. We also get fluid within the actual orbits themselves, and that causes the eye to be flattened. And that's one of the reasons why we need the space anticipation glasses. And here's just some pictures of astronauts, really showing the sort of orange pictures there are optic nerves, and what we see is normal optic nerves at the top, with then development of swelling, that blurred margin coming in. And this is not good because this could choke the optic nerve and cause visual loss. In the middle there, you see some retinal folds and some choroidal folds. This disruption could lead astronauts to be at risk of what we know about age-related macular degeneration, which is a choroidal neovascular membrane that can devastate eyesight without the treatments that we currently have. And just the globes on the right there showing the changes in the structure of the eye that for some astronauts do not resolve when they come back down to Earth. So SANS could compromise mission safety through not only visual blurring, forgetting your reading glasses when you're at work can certainly hamper your day, but it could also cause acute visual loss. And I've got some visual field changes. And if any of you have been to the eye clinic, you may be aware of that test that you go in and you see bright lights and you're pressing a button for us to be able to map your visual field. What is concerning is these central visual distortions, the fluid streaking towards the center part of the vision, the fovea. And we also believe that there may be potential for mild cognitive impairment. We see this in some of our patients with raised intracranial pressure. So presbyopia, the need for glasses, this was a nice picture of space anticipation glasses from the Specsavers group. Now, this isn't really as worrisome because we have the technologies with glasses, but we're seeing, you know, intraocular lenses and changes based on the fact that the astronauts need such a variation in their prescription as they go throughout flight. The real concern is this optic nerve swelling, and this was one of the first astronauts to show these changes, as I previously shown. So up to 70% of all long duration spacefarers get features of SANS, but only about 15% of crew members actually get clinically significant changes. And there's really no biomarker for a risk except if you've had previous SANS, and a lot of our astronauts are repeat flyers, it is highly likely that they will get SANS again when they go up into that microgravity environment. They've recently developed artificial intelligence models to be able to predict which astronauts will develop SANS. And this is really important for diseases on Earth because they've taken the astronauts many years before they've actually flown into space, and they can identify with the machine learning tool which astronauts would be at high risk of developing SANS. And this may unlock things for us on Earth in terms of us being able to screen patients or screen just normal people and work out what diseases they may get, not only of the eye, but in the rest of the body. All the studies on the International Space Station are on a volunteer basis. And so it makes it difficult for us to truly understand what's happening in SANS. So for example, on Earth, if I get somebody in my clinic with optic nerve head swelling, I'm thinking about doing a variety of tests. So I'm going to do neuroimaging, including MRI scanning to look not only at the brain, but also the blood vessels. And then I would go on and ask for a lumbar puncture. And this is an invasive procedure. And as you could understand, not only do they have an MRI scanner on the International Space Station, they certainly wouldn't want a lumbar puncture. And this has caused controversy in this condition as to whether this is an eye condition or whether this is an eye-brain condition. And they've spent quite a lot of time talking to different researchers around the world using different technologies. So the astronaut up on the left there is using some ultrasound. The gentleman down on the left there is having his eye movements tracked. And on the right there, the gentleman's leaning back, having a photograph of his optic nerve. And all of these provide information, but what really has changed our understanding of SANS is optical coherence tomography. So I'm just going to press this. This just shows my colleague James taking a picture of one of my research team's eyes. And it just shows you how quickly we can acquire a scan of the optic nerve. So within seconds, we can get a highly detailed three-dimensional image of the eye. And if any of you have been in eye clinic, you will know that you have these scans taken pretty much every time you come in. Now, this machine is quite special in terms of the detail that we get. And we're very fortunate in Kingston to just have received our first Spectralis, Heidelberg Spectralis platform. So I hope that we'll be able to use this in our patients, particularly not only in the clinic, but in research as well. So on station, they have to keep the Heidelberg in a box. It takes about 40 minutes to set it up. And as you'll imagine in microgravity, it's very difficult. They have to kind of hold on to the machine. Not only that, they also get calluses on the tops of their feet because as they move around the station, they're not able to weight bear. So they no longer get heels and cracked heels, but they get the tough skin on the top of the feet. So he's got his feet tucked under, so he's nice and steady for those scans. And I'll start to show you some pictures that we get from these scans. So this is centered on the optic nerve head. And what it's showing me is not only a beautiful anatomical rollout, but it's also giving me detail compared to normal people as to the elevation of the nerve. It also gives me lots of information about the blood vessels, and I can have a good look at the center part of the vision with the IR, the infrared image, the black and white image up there. So that's centered on the disc, and then on the right-hand side, it's centered on the center part of the vision, the fovea, the macula, the real sort of seeing engine of our eye, and gives us really great detail, not only of what's going on the surface, but all the way through that eye. And we use OCT to detect and monitor the eye. So no matter why you have eye swelling, maybe it's an ischemic optic neuropathy, or maybe it's brain swelling, we're able to map out detail by detail what is going on at the optic nerve, with increasing elevation causing a high risk for sight loss, with a normal on the right-hand side, as you see there. And generally speaking, if you leave nerve swelling, what happens is that you end up getting masses of swelling, and then it chokes the nerve, and unfortunately the nerve fibers die away, and ends up with really catastrophic visual loss without intervention. So moving away from the optic nerve, really the window to neuro-ocular health is something called the ganglion cell layer. And this is this purple layer that's highlighted on this schematic. Now, years ago, when we were looking at the eye without cross-sectional imaging, this was something that we didn't really understand, and we wouldn't have been able to monitor on a near daily basis. And the reason the ganglion cells are important is they are completely connected to the brain and the brain processing centers. And so it allows us, what I say is, a bi-directional information sharing. So if you have a problem with your eye, you can see changes in your ganglion cells. If you have a problem with the brain, you can certainly see changes in your ganglion cells. And the pattern of the changes helps me diagnose things before we even have an MRI scan. So what sort of things do I look at? I look at this beautiful, what we call is a donut. So it's a bright, normal, healthy donut here. And as I take you through, this might be somebody that has glaucoma, where you're starting to see loss of that bright change and moth-eaten appearance. But we get some really good, what I say is, figures and indices to be able to track patients over time and know when to intervene with medicines. And here we see somebody who's unfortunately lost all their ganglion cells, and their vision is very, very poor, just to show the comparison of the changes through. So I'm starting to allude to the fact that SANS is not just an eye disease. So with all these fluid shifts, it can't only just be an eye problem. And we know that we get fluid dysregulation because we're not able to clear the fluid, and particularly the fluid that actually goes up into our head early on. We get venous compression within the brain, and when we get obstruction of our outflow, whether it's due to thrombosis or stasis in the neck, which some astronauts get, that causes a vicious cycle and causes raised intracranial pressure. And certainly the scans that we've seen in space flyers following spaceflight show this narrowing of this CSF, the brain fluid spaces within the brain. We also see other things. We see expansion of the natural ventricles where our fluid is. And this doesn't necessarily resolve on people coming back down into gravity. And this is increasingly worrying us, because we don't feel that they're able to clear the sort of normal cellular metabolism that's going on in the brain. And is it putting our spacefarers at risk of diseases such as neurodegeneration and dementia? And this is just, again, another schematic showing these changes that have been carefully mapped by many researchers. And really, it's this failure to clear the brain fluid that is now concerning us, because we're seeing increased perivascular spaces within the brain. And we think this may be a marker of disease severity for SANS. But it's also a failure to clear fluid in the eye and the orbit. And this leads me to seeing the images of the sort of corrugated retina and choroidal folds, which normally you wouldn't see any undulation at all. And this kind of provides a break that membranes may seep in and cause age-related macular degeneration. We also see that the choroid expands during spaceflight, and this is just some images of that expansion. And really, on Earth, we haven't really explored the choroid as much as we could. And now with our new imagers, which have enhanced depth imaging, we'll now be able to look at those changes, because the choroid, the blood flow to the retina there, changes immensely during the day. If you have a glass of water or you have a glass of coffee, whether you do exercise, and we need to really understand what happens to the choroid during the day, and that may have very significant applications for some of the diseases we see of the retina, not only things like diabetic retinopathy, but age-related macular degeneration. But certainly for our space flyers, you see these striations. They almost look slightly pretty in the red, the reddy orange color picture of the back of the eye. But when you do that cross-sectional imaging with the OCT, it's really quite frightening to see the fluid and the changes underneath the retina, lifting it up and making some bright areas which are actually cell death within there. And we know that if you end up with a choroidal neovascular membrane from choroidal folds in particular, even if you have intravitreal injections that we treat similar to age-related macular degeneration, the vision falls and falls and falls. So it would render an astronaut, if they have this, from somebody that's able to drive to not being able to drive, not filling the MTO criteria. So this is actually quite frightening. And these changes are lifelong. So we know that the majority of changes, such as the optic disc edema, does resolve, but things like the changes, the presbyopic changes that we see, the globe flattening, and some of the measurements can persist for many, many years. And this is similar too for the brain. So we also know that veteran astronauts show these perivascular spaces that I mentioned earlier to be much larger than compared to what we say as rookies, astronauts on their first mission. So when we're thinking about moving to explore back to the moon, the Artemis mission, and onto Mars by 2038, we have to have solved these problems, because we cannot let our astronauts 9 months into a mission go blind without any kind of countermeasure or anything therapeutic. And to study stands, it's quite difficult to find an analogue, but we do have certain diseases that mimic some of the features that we see in our astronauts. There's a condition I'm going to introduce you shortly is called idiopathic intracranial hypertension. And I've touched quite heavily on the choroidal folds and age-related macular degeneration, but there's also some brain diseases such as normal pressure hydrocephalus. And the tools, as you've seen, is optical coherence tomography is really central to how they're monitoring SANS, and it's absolutely central to everything that we do in the eye clinic here in Kingston. There's some other tools that we may be able to use, such as parabolic flight, and I'm going to show you some pictures of head down tilt bed rest studies. And if we have time, I might show you a few pictures from Antarctica. So idiopathic intracranial hypertension is a very unusual condition. Predominantly happens in women and women of childbearing age, but I would say that men are actually catching up with this condition. They can get horrible, horrible headaches and these horrible swollen optic nerves. Obviously, there's a disease spectrum, so some people are mild, some people are quite severe. On the severe end of the spectrum, we get sight loss and we need surgical intervention. On the mild end of the spectrum, sometimes we need very little intervention. And the problem with idiopathic intracranial hypertension is the risk factor for this condition is actually living with obesity and recent weight gain. And we didn't see this condition, in the early 1900s. This is really a disease of our modern age. And so with the rising body mass index, we're seeing many more people get idiopathic intracranial hypertension. And so for my disease, this is what I see in clinic every week. As I said, we have people on the mild end of the spectrum. They need a diagnostic lumbar puncture. We often give them lifestyle advice, and we'll be thinking about the most commonly used medicine called the zetazolamide. And we'll also think about headache treatment because they get crashing headaches. In the middle of the disease, we're definitely treating this with medicines, but we don't have a good number of medicines we can actually treat this disease with because there are very few clinical trials in this disease. And at the more severe end of the spectrum, we're asking our neurosurgery colleagues or our interventional radiologists to help us with either a shunt or a stent, and that's to save vision. And we see about 1 in 10 patients that will require surgery to save their eyesight, but all patients need weight loss. When we think about SANS, our astronauts are very healthy and fit. They don't have excessive weight gain. If anything, they have weight loss, but we know that there are different disease mechanisms happening here. So what we've proposed is they need some sort of brain pressure lowering medicine, maybe for the mild so that they don't go to the moderate. But what are we going to do when they get to being severe? We're going to think about repatriating back to Earth. And at the present time, we don't have a treatment to mitigate the eye problems. And what's the problem with using acetazolamide on the International Space Station? Well, acetazolamide can cause acidosis, change the way that your metabolism is. It can cause horrible renal stones, which you certainly don't need on the space station, but it also can reduce the pressure inside the eye, which could make those choroidal folds less. And so it's been deemed not acceptable by NASA. So they were looking for an alternative approach. And this is one medicine that I think many people on the planet know quite a bit about: Ozempic, Wegovy, semaglutide. These are all GLP-1 receptor analogs. And as Bloomberg said, these drugs are coming and they could change everything. And we know that these drugs are here and they're certainly changing the lives of many people living with diabetes and people living with obesity. And it's one of the most commonly used drugs on the planet currently. What you may not know, and what this slide shows, is they can also lower brain pressure. So this was a study that I did with my colleagues in Birmingham. We used exenatide, which is a short-acting GLP-1 receptor agonist. And when we did the trial where we had women with intracranial pressure monitors, we were able to show that once the drug was on board, at 2.5 hours, the brain pressure was lower in those that were treated, at 24 hours, and all the way out to 12 weeks. And this is on the back of a long journey of discovery science, of understanding the medicine and how it would work within the brain. And so I've shortened it to 2 slides to give you a flavor of some of the repurposing of drugs and the different effects of the drugs that may be of benefit in different conditions. And really, it was this work that brought us to Johnson Space Center. And there in the distance, you'll see my first sunrise looking out over the International Space Station. But we're just standing there in mission control, and the chief medical officers there, along with some of my colleagues, and they were very interested in the work that we'd been doing in our women and wondered whether we'd be able to consider more work to be able to ascertain whether this medicine would be useful on the International Space Station and beyond. But the difficulty is with any repurposing of a drug, we have to show that it's effective in that condition. And so we look at our other tools that we have: parabolic flight and bed rest studies, and also Concordia. The problem with parabolic flight is we wouldn't have enough time. So the time that a person is in microgravity or 0G is seconds. And so you won't see the full effects at all of SANS that we see in our long space flyers. Now, parabolic flight is very good at looking at the neck vessels and seeing what changes happen in the major blood vessels, but it wasn't going to be a good tool for us to use. But actually, head down tilt bed rest may be. So this has been used since the 1970s, and really it helps explore immobility and fluid shifts and the way we change when, say, we're even in hospital for a day or 2 days or months. And there's been many findings that have been taken from these bed rest studies. But we find that patients in bed rest were not getting SANS until they realized that some of the participants had been given a pillow, and just giving a pillow and flexing the neck a little had saved them from getting the SANS-like features. So these experiments are done by healthy volunteers, and they can spend up to 70 days in bed with a 6-degree head tilt down. And so you can imagine how burdensome this is for the patients, but quite often they're quite excited about the new science that we're learning from bed rest. And they must do everything in this position. And it normally takes them a number of weeks to rehabilitate from these experiments. And we've been fortunate enough to secure a grant to be able to do a randomized controlled trial using the exenatide, just like we did with the women on Earth. And that will be starting in January next year. And we'll be running 3 missions at the German Aerospace Center using sort of their highly it's just awesome environment. It's just a really beautiful research facility. And what we'll be looking at is seeing those patients in bed rest that develop SANS and whether exenatide can reduce their chances of that eye nerve swelling. So it brings me back to how will our patients in Kingston be helping? Well, we have now the Heidelberg scanner, which arrived only but a few weeks ago. And we'll be asking our patients to sign up to a research program called the Optic Neuropathy Pathophysiology and Translational Clinical Research Program. And essentially what this is being able to scan all our patients across many, many different diseases to start to develop tools, not only to have that cross-section of healthy volunteers, but also people living with sight loss, to see if we can pick up the earliest signs of sight loss. We really want to understand these structures. And then the converse of that is, how will our patients in Kingston be helped by the research that we're doing? Well, you know, the astronauts are healthy before they go up into that environment. And there are certain findings that we're seeing on the eye scans that's now starting to help us to understand our diseases here on Earth, particularly raised intracranial pressure. We'll be able to use astronaut data and be able to compare that to our Kingston research cohort. I hope it will help us develop new models to detect these early stages of diseases, including eye and brain diseases. A lot of work has been done in neurodegeneration, Alzheimer's and dementia, and we wish to build on that. We also want to think about new medicines and also new ways to deliver drugs, because at the present time, you can imagine you can't quite get an eye drop to stay on an eye in space. So we have to think of novel, non-invasive ways of delivering drugs. Oh, I'm sorry, it's just the printer going in the background. Just in the last few minutes, I've got some slides. This is a picture from one of the Mars rovers. And just to let you know, maybe I'll come back and talk to you about relativity at some point. So we were able to send an OCT scanner and an MRI scanner to Concordia base on Antarctica. And you may wonder why we were doing this. Well, Concordia sits at 4,000 meters above sea level. It's a highly dry and inhospitable environment. And we had 12 participants of the station that overwintered there. We wanted to look at hypoxia and hypoxia in the brain and the eye. And so you can imagine how remote Concordia is, but our participants, the people that work on the station, get chronic hypoxia. They also get other stressors due to confinement and isolation and changes in their normal, what we say, circadian rhythm and problems with sleep. And so we were looking at understanding that everything is connected from the heart to the head. And in the middle there is a hyperfine MRI scanner, an MRI scanner that could sit in the corner of my clinic, I hope, one day in Kingston, where you're able to use the scanner just using a simple iPad, and very, very straightforward, using machine learning to be able to enhance the images. And so some of the work that we've done here, we hope to be moving forward with our results in the not too distant future. But just some nice pictures there just to show some of the additional work that we're doing. And the building there, the FE Hab, is the DLR where we'll be doing our bed rest studies from. So I would love you to tell everybody about the research that we're doing in the eye department at Hotel Do. I really do believe it's contributing to the advancement of humankind, not only travel in space, but also hopefully to solve some of the problems we have with blindness across the world. Many thanks. I'm really happy to take any questions.
Yes, Marie, is it okay to take questions now, or would you like me to introduce John?
I think it would be great if Susan introduces John, and then maybe we can do questions after that.
Yeah, so before you do that, Dr. Mullen, thank you very much for that incredible presentation. There's so many layers to that that are just beyond fascinating, including the people that spent 70 days laying down and participating in this incredible research. So yeah, thank you very much. And yeah, please, back to you, Dr. Mullen.
Lovely. So it's a real pleasure to introduce John, who's had a long history with healthcare in Kingston. He, I think, first met eye services many years ago, but received a corneal transplant here within our services. And so it's just absolutely wonderful to have John here to talk about the eye clinic and the good work that all the physicians do, from the clinical delivery to research. Thank you, John.
Hi, everybody, and my apologies at the beginning of the call for my lack of technology and turning my mic off. The anxious call from Lisa Riley got me to catch up. Susan, it was interesting to hear that you talk about 1 in 7. You know, that's 40 or 50,000 people in our catchment area that are going to need services or do need services. I'm just going to talk very briefly about my eye journey and lead to the question and answer. And it has some linkage to your discussion about research. I first noticed eye problems when I was in high school in Brockville, and I was a young rower. And I guess, Susie, your son is as well. But I was a young rower, and I realized I couldn't read the names on the ships. And so that led me to a trip to the optician and glasses, which was a whole new world for me. Suddenly, black was blacker and white was whiter. It was in my university years, though, that I realized that even with the glasses, I was having trouble seeing from the back of the class. So I went off to student health services, and interestingly, a young doctor there said, "I think you have an eye disease called keratoconus, and we're going to refer you to the Hotel Dieu clinic." That's where I met Dr. Willis, who did indeed diagnose me with keratoconus, which is a growing of the cornea into a cone shape. The correction at the time was wearing contact lenses. That led me to Dr. John Morgan, who was a partner with Dr. Wendell Willis, and that put me in a research study for what was then called the Boston lens, gas permeable lenses, which improved the wearability of contact lenses. And so at the time I was on the Queen's hockey team, and suddenly I became a better hockey player because I could see the puck a lot more clearly. It wasn't until many years later, around 1979, 1980, that I went through a period of extreme stress in my life. And it's interesting to hear Dr. Mullen talk about the relationship with stress and the eye. My employer was killed in a plane crash in June of 1979. 1st of July of 1979, we moved into a new house, and the 20th of July, we had our second child. And so, not only was he killed, but the person I had hired to replace me in our company was killed with him. So then I had to take that job over. And the day later, another individual in our company had a heart attack, so I had to take his job over. And so my eyes suddenly deteriorated. And so in late 1979, I had my left cornea transplanted. In 1980, my right cornea transplanted. And then everything was pretty stable for quite a period of time. Dr. Tenhove, I would see him maybe once a year. But about 10 years ago, the left cornea failed. So I had to have a cornea transplant. Dr. Stephanie Baxter did that transplant, and she also replaced a cataract, or repaired a cataract at that time. About 5 years ago, I was diagnosed with glaucoma, and about 3 years ago, I had surgery for glaucoma in my left eye. And then last year, that second cornea transplant began to fail. I guess that's common with glaucoma surgery. So Stephanie did what's called a DMEK, and you docs can explain what that is. But for us laymen, it was just replacing the inner layer of the cornea. So that was done last October. At the time of being diagnosed with glaucoma, I also had age-related macular degeneration, and I've been going in every month for a couple of years. It was every 3 months, and now it's every month for an injection into the left eye for the macular degeneration. Meanwhile, my right eye, that cornea now, which is supposed to have a 25-year lifetime, is now at 45 years. And this people that know me are tired of hearing this, but when I was 30 and I had a cornea transplant from a 55 or 60-year-old, I used to say I have an eye for the older ladies, and now I've got a 45-year-old cornea. I've got an eye for the really old ladies. It's about a 95-year-old cornea, and it's going to go at any time. So I've lived through cornea transplant. A couple of years ago, retinal swelling that was treated at the Galen Eye Clinic with Dr. Gupta. Dr. Singh at Galen did my glaucoma surgery. I've had cataracts, I've had glaucoma, and I've had macular degeneration. So you name it in the eye field, and I've had it all. We're so fortunate in Kingston to have the level of care we do for a community our size. And we're so fortunate to have researchers like Dr. Mullen. And I believe that those of us who have been fortunate, I've been fortunate with the healthcare, but I've also been fortunate in business. I think we have an obligation to give back. And so I've offered my services to raise funds for a clinical chair in translational ophthalmology. And essentially what it means is these great researchers at the University Hospitals, Kingston, will be able to take their research and translate it to the patient right here in Kingston. Take the patient to the research, take the research to the patient. So this fundraising campaign is just beginning, and there may be some people on this call that will get a call from me. There's a naming opportunity. It could be the clinical chair of. So I'm fortunate. I'm grateful. I can't thank the doctors that have looked after me. I'm one of thousands in Kingston that have been so fortunate with the eye care. And I'll turn it back to you, Dr. Mullen, with appreciation for everything that you're doing.
Oh, thank you, John, for that. And, we also want to thank you for the fundraising for this, because we have such a phenomenal team here and a unique environment. The organization supports research, and I can tell you many organizations don't. When times get hard, research is the first thing that goes out of the window, and without research we can't move forward. And I think it's lovely that you had a corneal transplant, and then with research, they were able to work out that actually they didn't need to replace the whole cornea. They only needed to replace certain layers. And that has saved so many people's sight. So no, truly, truly wonderful.
Yeah, incredible story, John. Thanks for taking the time to share that with everybody, and for the closing remarks around your continued support and generosity for the innovation and support that we all benefit from today and yesterday, based on your contributions and influence over the years. We'll now move into a few minutes of questions from our audience. And just a reminder, if you have a question, please enter it into the Q&A feature at the bottom of the screen, and we'll do our best to bring as many of them forward as possible.
So just looking at those, Janine, thank you for your question about acidosis. I know I quickly skipped over that. That can actually be caused by some medicines, particularly azidazolamide, which we used for raised brain pressure, but we also use in glaucoma. And that's where you end up with too much acid within your blood. And so it causes problems because the kidneys are not able to regulate the sort of pH, the acid alkali balance of your blood. And that actually causes breathing difficulties. And so for the astronauts, the last thing we need is any kind of breathing difficulties where they're not able to get rid of their carbon dioxide. Carbon dioxide is a real problem on the space station. When they initially went up, they had, it was nearly 15 times the amount of carbon dioxide that we have here on Earth. And they were very worried that that was causing vasodilation and maybe contributing to SANS and other health problems. They've managed to be able to reduce the amount of carbon dioxide to about 5 times on station. So it's not only the acidosis, but also the exercise that the astronauts have to do on a daily basis to maintain their bone mass and also their muscle mass. And so we really, the idea of giving azidazolamide would be awful for them to take, because it would cause a whole host of other problems in terms of their normal daily health there. Let's have a look. Are there any preparations prior to spaceflight that might mitigate the impact of zero gravity on astronauts while in space? I think so. A number of different things when we think about the microgravity environment. You can create gravity on the International Space Station, but it's incredibly expensive and cumbersome to create gravity there. And one of the reasons that Artemis mission is going to be very helpful is that's going to be a moon base and give partial gravity to be able to explore new therapies and also do many other different types of experiments. In terms of what we already have, there's something called lower negative body pressure suits, and these are quite cumbersome suits that actually the Ross cosmonauts have been using for a number of years. And that does seem to mitigate and pull the fluid away into the lower extremities. The problem is we don't know how long astronauts need to be using the lower negative bodysuit a day. You know, is it 4 hours? Is it 6 hours? And what I wasn't quite aware of is each astronaut has a timeline. They chase this thing called the red line. Every 5 minutes of their life on station is documented in terms of what they should be doing. And so you can imagine when they're doing careful experiments or even maintenance on the space station, having a cumbersome suit around them that's sort of pulling fluid down for hours on end is quite stressful. So that is one thing that is being used currently. And then the other idea is obviously if we have medicines that are safe, such as exenatide that has a long history on Earth, doesn't have the side effects of some of the other medicines, could we treat the astronauts, pre-treat those ones that we identify at the most highest risk of having SANS with something like exenatide or another medicine. And that's certainly one of the reasons why we're doing a lot of the research to find out whether there is something we can either give prophylactically so they don't develop SANS, or use when they get to a point in the disease where maybe it's a tipping point that they could be becoming more severe. Oh yes, we'll all be recruiting. So we are very fortunate at Hotel Do to be afforded more space for the ophthalmology department. So not only are we on level 6, but we've also moved into level 2, and the neuro-ophthalmology and glaucoma service are on level 2 now. And so once we're up and running, this study will be for people in the clinic. They'll be asked, taken through consent as to whether they want to participate. But we'll also be looking for healthy volunteers, and we will be advertising that in local media. So I'm very excited that it will be not only people in the hospital, but also normal people of Kingston that don't have eye disease, because they're going to be equally important for us. Yes, so we also hope, we're just rejigging the research page of the Department of Ophthalmology. So there will be a button on there that says, how can I participate in various research activities. So it's not only the optic program, we are looking currently in discussion with bringing a number of different clinical trials to Kingston, which is incredibly exciting, as the university has a new clinical trials unit. And I think it just across a number of different eye diseases, including glaucoma, optic neuritis, such as MS optic neuritis, and something called non-arteritic anterior ischemic optic neuropathy. Those diseases are going to be the first diseases. So very exciting. And we will get our researchers pages up and going, so you'll be able to see what activities. And I do hope that we'll be hosting an open evening in the coming year to let people know what we're up to. So thank you so much for those questions.
Yeah, thank you very much, Dr. Mullen, and Janine, Sandra, Ross, Tracy, Sandy, for those good questions. Nice way to close off today's session. So as we wrap up this morning, I want to extend a sincere thank you to you, Dr. Mullen, and to you, John, for sharing your insights and experiences with us, and for all of your commitment to our community. Your work and your stories remind us why continued investment in research, innovation, and patient care is incredibly important. And to everyone who joined us today, sincere thank you. Your support of University Hospital Kingston Foundation plays a vital role in ensuring that our hospitals and care teams have the resources they need to continue advancing healthcare for our entire region, as Dr. Mullen has illustrated for us today. If you'd like to watch today's session again or share it with friends and family, which I'm sure many of you will, the recording will be available on our website and YouTube channel, and you'll receive an email tomorrow with that link. I'd also like to invite you to join us for our next Circle of Care webinar, which will be held on April 1st at 10:30 a.m. Family, Philanthropy, and Peace of Mind, the Role of Life Insurance in Your Financial Framework is the topic of the next Circle of Care webinar. It will feature Rick Tumulty, President and Managing Partner of Caldwell Wealth and Estate Advisory. You can register on our website at uhkf.ca, and the link will also be included in tomorrow's email. Thank you again for joining us this morning. Wishing you all a wonderful day, and please stay well.